the session 1, which is on multiple myeloma and associated renal disease. And we have very eminent speaker to take us through today's session as well. The MentorSpeak program is basically a Zoom webinar platform meeting where we have designed the agenda in close collaboration with our program moderator and speakers. And also we have taken feedback from you in order to fine tune the topics of the meeting and also to include some case presentation, which will definitely differentiate this program from other meetings which are currently happening. For this program, we are obviously using the online platform. So in case you drop out, then please log in with the help of the same link which you have received. Ratush, can we move to the next slide? The main objective of this program is to connect to the curriculum, and also the program range from unmet needs in the current curriculum to the setting up the clinic and also medical legal issues linked to it. And we have really a very eminent nephrologist across India joining us for this program. Next slide. Yeah. So this is the basic outline of the program. It is a 1 hour duration, very crisp, so that we don't take much of your busy time schedule. And the program would have a presentation on the topic around 20 minutes, then case presentation of 10 minutes. And this is followed by very interactive question and session for half an hour where you can voice your questions and also learn from your mentors. Next slide. As I said, this is an online program. So in case you drop out, please use the same link to log in. Next slide. And it's my pleasure and privilege to invite today's moderator and course coordinator, Professor Dr. Vijay Kher, sir. He doesn't need any introduction. He's very renowned. He's the president of Kidney Foundation and Education Network, chairman of Medanta Kidney and Urology Institute, Division of Nephrology and Kidney Transplant Medicine at Medanta, the Medicity. Next slide. He has been the regional coordinator, Research South Asia, International Society of Nephrology. He has been the inspector for DMB and DM recognition for National Board of Examination and Medical Council of India. And that speaks to that why we are bringing Professor Dr. Vijay Kher as our moderator and course coordinator for MentorSpeaks program. He has set up successful nephrology department at SKIMS Srinagar, SGPGI, Lucknow, Apollo, New Delhi, Fortis, and Medanta, Gurugram. So with this, I would like to now invite Professor Vijay Kher, sir, to take us through the proceeding. And thank you so much, sir, for joining us today and your valuable time. Over to you.
Thank you, Arvind. Good evening, ladies and gentlemen. It's a pleasure for me to be back here again, and it's a great privilege that we are starting this program on 2nd October. And as Arvind said, that this should be an auspicious kind of an occasion for us to start this new program. This is the feedback we got from you. Actually, MQR helped us to get a survey done, and we picked up the kind of mentors that you wanted and the topics that you wanted to discuss. And it will be our endeavor to provide a clinical kind of based discussion on some of the unmet needs of education, as well as unmet needs, discuss some of the finer aspects. You're going to get the best of the nephrology teachers existing in the country, and with this medium, fortunately, we should be able to bring you the best of the country. And I have a great privilege and a pleasure to bring the first person, and there can't be anyone better than Professor Vinay Sakhuja. Vinay Sakhuja doesn't need introduction to all of you. He has been professor and head of nephrology at PGI Chandigarh, and currently he is the director of nephrology transplantation at Max Super Speciality Hospital, Mohali, Chandigarh. He has been an emeritus professor, former dean, and more than that, an extremely erudite and superb clinician, a superb teacher, and an exceptional human being. So it's a privilege for me. He's been a friend and a colleague with me for more than 45 years now. We were together at PGI, and it brings in a lot of old memories too, which I have had with Vinay, and it's been a pleasure to continue to interact with him. I always learn from his lectures, and I'm sure you're going to find today's lecture as well. So Vinay, it's all yours, and thank you. Thank you for picking up this first lecture.
Um, am I audible?
Yes,
Yes, sir.
Vinay, you are.
Yes.
Yeah.
So thank you very much indeed, Professor Kher, for that very kind introduction. I'd like to thank MCure Pharma and Professor Kher for giving me this opportunity to participate in this MentorSpeaks program and to be the first speaker in this series. And today I'll be speaking to all of you on the subject of myeloma associated renal disease. May I have the next slide, please? I'd like to start by presenting to you the clinical data of a patient that we saw earlier with myeloma. This was a 66-year-old male whom we first saw in January 2019, and he presented with pedal edema and frothy urine of 3 months duration. We investigated him and found that his serum creatinine was 2.9 milligrams per deciliter. The urine showed 3 plus albumin urea. The 24-hour urine protein was 7.3 grams a day. The serum albumin was only 2.3 grams per deciliter, and the hemoglobin 11.4. We did a kidney biopsy since the kidney size was normal, and this showed that 9 out of 15 glomeruli was sclerosed. In the remaining glomeruli, there was mesangial expansion and GBM thickening. There were several fractured eosinophilic casts in the tubules. There was interstitial inflammation, and there was eosinophilic material in the walls of the arterioles and small arteries. And this material exhibited Congo red positivity, but the glomeruli were not Congo red positive. Immunofluorescence showed deposition of only lambda light chains along the glomerular basement membranes, in the casts, and in the small arteries. So with these biopsy findings, a diagnosis of monoclonal immunoglobulin deposition disease resulting from lambda light chains, along with a cast nephropathy and vascular amyloidosis, was made. There was no glomerular amyloid, and the patient was further investigated. The serum protein electrophoresis, as expected, showed an M spike. The free light chain measurement was done in the serum, and this showed a kappa lambda ratio of only 0.2, which in a patient with renal insufficiency should range between 0.37 and 3.1. So this showed that the lambda chains were significantly elevated as compared to the kappa chains. The bone marrow examination revealed 26% clonal plasma cells. There were no bone lesions on the skeletal survey, and the patient did not have a hypercalcemia. So these were the details of this patient. And I'll come back to this case later in the course of my presentation to highlight some of the important facets of this patient that would also throw a lot of light on the fascinating aspects of this disease. May I have the next slide, please? So multiple myeloma accounts for about 10% of all hematological cancers. The median age at which this occurs is around 65 years, maybe around 60 years in India. But it's important not to consider this only a disease of the elderly, and you can have myeloma rarely, even at the age of 40. So don't ignore this possibility if you have a middle-aged patient. Patients with myeloma often begin with an asymptomatic pre-malignant stage, which is called monoclonal gammopathy of unknown significance. And this stage can last as long as 10 to 15 years. And this then goes on to what is called smoldering myeloma, and that finally leads to a full-blown active myeloma. So these three together constitute what is called a myeloma disease continuum. Now, in about 25% of patients with multiple myeloma, there are genetic mutations which can be identified, and these, if present, confer a high risk to these patients, and such patients require more aggressive chemotherapeutic regimens. Renal insufficiency is seen in up to 25% of patients right at the onset of myeloma, and in up to about 50% of patients during the subsequent course of the disease. The next slide, please. So what are the criteria that have to be satisfied before one can make a confirmed diagnosis of multiple myeloma? You need to have clonal marrow plasma cells that constitute more than 10% of all the marrow cells. And along with that, you should have one or more of the so-called myeloma defining events, which are also referred to as CRAB. And now CRAB stands for hypercalcemia, renal insufficiency, anemia, and bone lesions. So you need to have at least one of these four criteria along with the marrow plasma cells for a diagnosis of multiple myeloma to be made. A monoclonal gammopathy is present almost invariably. Only 2% of all patients with multiple myeloma will not have a monoclonal gammopathy. The next slide, please. Now, about 15 to 20% of patients with multiple myeloma will present at the onset of the disease to a nephrologist and not to a hematologist or an internist. And it is this group of patients in whom one needs to have a very low threshold to investigate for myeloma. So in any patient who presents with chronic kidney disease or acute kidney injury of unknown etiology, one must look for this possibility. There are certain clues which can point towards myeloma as a possibility. in these patients. One of these is the presence of anemia out of proportion to the degree of renal insufficiency. However, the absence of anemia certainly does not exclude the possibility. Hypercalcemia is a feature of 10 to 15% of all patients with myeloma and is another important clue. And yet another important one is hyperglobulinemia. In diabetics, if renal involvement is present, we generally tend to presume that this is diabetic nephropathy. And it is in this group of patients that the diagnosis of myeloma is very likely to be missed for this reason. So therefore, in diabetics, if the diabetes is of very short duration, or if there is no albuminuria, or if a patient has rapidly progressive renal failure, one should always once again investigate for this possibility. Failure to diagnose myeloma in such situations, besides leading to a delay in treatment, sometimes can lead to a nephrologist going ahead with a kidney transplant if the patient is already in end-stage renal disease. And that can be a real catastrophe because the kidney involvement can recur because of myeloma in the transplanted kidney, leading to loss of that kidney and leading to tremendous embarrassment for the nephrologist, including medico-legal consequences. So that's something I hope none of us ever have to face. The next slide, please. So how does one investigate these patients? Serum electrophoresis for long has been the gold standard, and it is an inexpensive test, but not very sensitive. It does not distinguish between polyclonal and monoclonal abnormalities, and it only identifies intact immunoglobulins. It does not identify free light chains. So the next step would be an immunofixation electrophoresis. This is far more sensitive and also identifies the immunoglobulin subtype that the patient has. For instance, it tells you whether the patient has a IgG myeloma, which is the commonest, or a IgA myeloma, and so on. However, to identify free light chains, you need a serum free light assay, and from that you can determine the kappa lambda ratio. In patients with normal renal function, the kappa lambda ratio should range between 0.26 and 1.65. In patients with renal insufficiency, the levels of both kappa and lambda light chains are going to be elevated, but the ratio is also altered. So the ratio ranges between 0.37 and 3.1 in those with renal insufficiency. And if it's outside this range, then it is significant. Next is examination of the urine, which one needs to pay a lot of attention to. Now, if you are looking for light chain proteinuria, the dipstick detects only albuminuria, and it will be negative if there is only light chain proteinuria. So for detecting light chain proteinuria, you need either a sulfosalicylic acid test on the urine, or you need to do both a protein creatinine ratio and an albumin creatinine ratio. Now, if a patient has only light chain proteinuria, it will show up on the protein creatinine ratio, but the albumin creatinine ratio will be normal. Whereas if you have albumin in the urine, only albumin, it will show up in both the PCR and the ACR. So that's the value of doing both these. And of course, you can distinguish between light chain proteinuria and albumin urea by also doing a urine protein electrophoresis. It's important to remember that some patients may have both light chain proteinuria and albumin urea. These are the ones who have either glomerular amyloidosis or a monoclonal immunoglobulin deposition disease, as we'll come to in a short while. Estimation of the serum LDH and beta-2 microglobulin levels is also useful, particularly for staging of multiple myeloma. The next slide, please. And this shows you the international staging system that is currently in use. Those with stage 1 have a serum albumin level that is normal, a beta-2 microglobulin level that is also normal, less than 3.5 milligrams per liter, no high-risk cytogenetics and a normal LDH, whereas those with stage 3 have an elevated beta-2 microglobulin, high-risk cytogenetics, or an increased LDH level. Those which do not have features that can fit into stage 1 and stage 3 will be those who will be assigned to stage 2. Here I'd like to emphasize that in all patients who have renal insufficiency, the beta-2 microglobulin is no longer useful, since it would be elevated simply because of renal insufficiency in all those patients. The next slide, please. Now, coming to the various forms of kidney injury, and this is a very important slide. In the vast majority of patients, that is about 76%, the kidney injury is paraprotein dependent, whereas in the remaining 24%, kidney injury is independent of the paraproteinemia that is present. And the commonest type of kidney injury amongst the paraprotein dependent group is cast nephropathy, which accounts for about 1/3 of these. Monoclonal immunoglobulin deposition disease and AL amyloid are almost equally common, accounting for just over 20% each of this group. Rarely you can have a proximal tubulopathy, which results from deposition of light chain proteins in the proximal tubular epithelial cells. At this point, I might also remind you, I talked of the urine examination already and about light chain proteinuria, and you would recollect the classification of the types of proteinuria into glomerular proteinuria, tubular proteinuria, overflow proteinuria, and tissue proteinuria. And patients with multiple myeloma who have light chain proteinuria. So this is actually a form of, or an example of, overflow proteinuria, because here the ability of the proximal tubule to deal with the large quantities of light chains that are being filtered by the glomerulus is overwhelmed, and that is why you get light chain proteinuria. The proximal tubule cannot deal with those, and that is why this is called a overflow proteinuria. Now, coming back to the types of kidney injury, paraprotein independent forms of kidney injury can result from hypercalcemia, hyperuricemia, volume depletion, sepsis, nephrotoxic drugs such as non-steroidal anti-inflammatory agents, bisphosphonates, and rarely also from direct plasma cell infiltration of the kidneys, which can sometimes occur in the pre-terminal stages of multiple myeloma. So often there is a combination of these factors operating when you have paraprotein independent acute kidney injury. In some patients, you can have a combination of paraprotein dependent and paraprotein independent kidney injury. And it's also possible to have two types of paraprotein dependent kidney injury in the same patient. For instance, you may have cast nephropathy and amyloid, or cast nephropathy and MIDD in the same patient. May I have the next slide, please? Now, what are the clinical syndromes with which these patients with kidney involvement can present? Acute kidney injury is one of the common clinical syndromes. Now, this could result from cast nephropathy commonly, but it could also result from paraprotein independent mechanisms that I have just talked about. You may have a rapidly progressive renal failure, which also can result from a cast nephropathy. You may have a nephrotic syndrome or subnephrotic albuminuria, and this can result from monoclonal immunoglobulin deposition disease or amyloidosis. You may have at a later stage the development of chronic kidney disease or end-stage renal disease, which may result from cast nephropathy that has not recovered, or from amyloidosis or monoclonal immunoglobulin deposition disease. In rare instances, you may have Fanconi syndrome, which is a manifestation of the proximal tubulopathy that I referred to a short while ago. Patients with cast nephropathy are generally, most of the time, non-oliguric. The kidney sizes in these individuals are normal, and the urine sediment usually is inactive. The next slide, please. Now, coming to the mechanisms of renal injury, in cast nephropathy, casts are formed in the distal nephron, and these result from a co-precipitation of the filtered light chains along with tam horsefall protein. And subsequently, there is rupture of the tubular basement membrane in the distal tubules, followed by the development of tubulointerstitial nephritis. The risk of cast nephropathy depends on certain characteristics of the light chains, which we don't understand very well, and the risks also increase with the quantity of light chain proteinuria. In MIDD, there are deposits of intact immunoglobulins, sometimes heavy chains or light chains along the glomerular basement membrane and the tubular basement membrane. The light microscopic appearance is one of nodular glomerulosclerosis, similar to that of diabetic nephropathy. And most such instances occur with kappa light chain proteinuria, and these kappa light chains are in the form of monomers in the urine, and they have a molecular weight of about 22,000 kilodaltons. In patients with amyloidosis, there's usually a lambda light chain proteinuria, and the lambda light chains are usually exist as dimers with a molecular weight of around 44,000 daltons. it's important to remember that it's not only the kidney that gets involved in patients with myeloma, particularly when you have amyloidosis or MIDD, you can have involvement of organs other than the kidney as well, in particular the heart. May I have the next slide, please? So, how does one manage the acute kidney injury in these patients? The first step is, of course, to optimize the hemodynamics and the intravascular volume. If there is any hypotension or fluid depletion, one needs to treat sepsis if there is any, withdraw nephrotoxic drugs to which the patient might have been exposed. One needs to treat hypercalcemia and hyperuricemia. Alkalinization of the urine can be carried out provided there is no hypercalcemia. Patients who have paraprotein independent acute kidney injury will generally reverse completely with the measures that I have just listed, and the kidney function will generally come back to normal. However, amongst those with cast nephropathy, only 40 to 50% may recover, and even those who recover may take a long time for that recovery to occur. The next slide, please. So one often needs to consider doing a renal biopsy in these patients. So what would be the indications for doing a renal biopsy? So if you have a patient with kidney injury, then you certainly don't need a biopsy. But if the creatinine rise is persistent or the recovery of the renal insufficiency is incomplete, then definitely a biopsy would be indicated. If there is persistent albuminuria, because this would definitely mean that the patient has paraprotein dependent disease, and this would be an indication for biopsy. So these are the important indications for doing a biopsy. And when you do a biopsy, it's important to, besides staining with H&E and PAS, you should also do a Congo red stain. And immunofluorescence is very important. And this should include staining with anti-kappa and anti-lambda sera. If possible, EM should also be done. The biopsy should be examined with a pathologist, by a pathologist who has significant expertise in dealing with such biopsies. And the biopsy, of course, has prognostic significance as well. The next slide, please. And this is to show you the typical low power appearance of a past stain of a patient with a cast nephropathy. And you can see the numerous pink staining casts filling up at least 7 or 8 of the tubular cross sections in this slide. And you can see some of the casts have fracture lines and some of them have surrounding giant cells. There's also some interstitial inflammation that you can see. The next slide, please. And this is a high power view of a Jones stain of a patient with cast nephropathy. And because of the Jones stain, the tubular basement membranes have been stained black. And in this tubular cross section, you can see a typical myeloma cast with fracture lines. And at the lower edge of the cast, you can also see syncytial giant cell formation. These giant cells are thought to be of macrophage origin. The next slide, please. At this point, I'd like to come back to the clinical case that I presented at the start to highlight some of the important facets of that patient, which you can now analyze after having heard a large part of my presentation. So that patient had renal involvement right at the first time when he presented. And because of that, he presented to a nephrologist and not to a hematologist or an internist. Interestingly, his hemoglobin was 11.4, so he really didn't have much anemia. So that highlights the fact that the absence of anemia does not rule out a multiple myeloma. That patient presented with a nephrotic syndrome since he had significant albuminuria and hypoalbuminemia. He also had renal insufficiency. And so since this appeared to be consistent with paraprotein dependent disease, we went ahead with the biopsy, and the diagnosis of myeloma in this patient was first suggested by the renal biopsy itself because he had a cast nephropathy, which is a myeloma defining event. He had MIDD, he had amyloidosis, and he had lambda restriction in the immunofluorescence. And this patient was also very interesting because he had 3 different paraprotein dependent lesions at the same time in the same biopsy. This is not something very common. You will often see, most of the time, you'll see only a cast nephropathy or only amyloid involving the glomeruli or only MIDD involving the glomeruli and the tubules. But this patient was unusual in that he had a combination of 3 different paraprotein dependent lesions at the same time. Now, this patient was treated with a combination of bortezomib, cyclophosphamide, and dexamethasone with a good response as far as the myeloma itself was concerned. However, the kidney disease did not show much improvement, and the serum creatinine currently, more than 1.5 years after his initial presentation, is around 3.5 milligrams per deciliter. Of course, I'll be happy to take up any questions related to this case at the end of my presentation. So maybe go on to the next slide, please. Now coming to the important and controversial area of extracorporeal light chain removal. This is something that needs to be considered only in patients who have purely a cast nephropathy. The first method that was tried was plasmapheresis. However, in the largest randomized controlled trial that was done in 2005, no benefit could be demonstrated. In fact, 40% of even the control group recovered, indicating that just chemotherapy alone can help in these patients. Leung et al. Subsequently did a study on 40 patients and showed that patients who had a 60% reduction in the free light chain levels at the end of 3 weeks after plasmapheresis were associated with a recovery in 80% of those patients. However, both these studies were done in the pre-bortezomib era, and since a lot has changed in the management of myeloma in the last decade, so therefore these are not considered evidences in favor of plasmapheresis. In the bortezomib era, from the same Mayo Clinic group, only one study has been done, and this included just 14 patients. However, it did show that 86% of these patients showed either a complete or a partial response to plasma exchange. However, this was not a randomized controlled trial. So the rationale has been questioned, and it has also been doubted because of the fact that light chains are present in the same concentration both in the intravascular and the extravascular compartments. Nevertheless, in case you do want to do plasma exchange in these patients, you need to do it daily until the free light chain levels have come down to at least less than 50 milligrams per deciliter, and then continue it as and when required till the chemotherapy takes effect and brings down the light chain levels by itself. The next slide, please. Now, the other method of extracorporeal light chain removal is by high cutoff dialysis, and there have been 2 randomized controlled trials of this kind of dialysis. This dialysis involves using dialyzers which has a membrane with a large pore size which allows molecules of between 45 to 60 kilodaltons to pass through. The first trial was the Meyer trial, a multicentric trial which included 98 patients with cast nephropathy proven by biopsy. And this showed that at 6 months, a significant number of patients were independent of dialysis, and this dialysis independence was preserved at the end of 1 year. And all of these patients received bortezomib and dexa as the chemotherapeutic regimen. May I have the next slide? However, the second trial, which was ULIGHT, which included 90 patients with biopsy-proven cast nephropathy, showed no difference in dialysis independence at 3 months between the 2 groups, and the 6 and 12 months outcomes were somehow not reported, and they also reported more pulmonary infections in the group on high cutoff dialysis, and therefore this left the issue unsettled. So the Meyer study has suggested that HCO dialysis is useful. However, other experts feel that more studies are needed. Of course, if you do high cutoff dialysis, you need phosphorus and albumin supplementation while you're doing this. And it's important to remember that this form of dialysis is not available in India. It's very costly. So in India, if you want to remove light chains, you have to go back to the old method of plasma exchange. The next slide, please. Now, coming only briefly to chemotherapy, this is the territory of the hematologist, and I don't think the nephrologist should try to do this on his own, because it is far more complicated than this slide would tend to indicate. I've tried to simplify it on this slide for you. So in patients who are under 65, or you can even extend that to 70 years of age, and who don't have comorbidities and who have a good performance status, these patients can be candidates for an autologous stem cell transplant So you treat them with bortezomib, lenalidomide, and dexamethasone, and then subsequently take them for a stem cell transplant. And following that, you maintain them on lenalidomide therapy. In some patients who have genetic mutations and therefore are at a higher risk, you should preferably use an additional drug, that is daratumumab, along with bortezomib, lenalidomide, and dexamethasone, and then consider them for a stem cell transplant. And the maintenance therapy drug in them would be bortezomib. In patients who are above the age of 65 to 70, have comorbidities, and are not going to be considered for a stem cell transplant, then bortezomib, lenalidomide, and dexa, followed by lenalidomide alone, is the therapeutic regimen that is preferred. I'd just like to mention two major side effects. With bortezomib, the major complication is peripheral neuropathy. Venous thromboembolism is the major complication, whether with lenalidomide and thalidomide. And myelosuppression, of course, can be a complication with all these agents. All patients with myeloma are at great risk for infections, both with and without neutropenias. So they should receive the pneumococcal vaccine even before they are put on chemotherapy. And while on chemotherapy, they should be on prophylactic cotrimoxazole, acyclovir, and possibly fluconazole as well. The next slide, please. What about patients who go on to end-stage renal disease and require dialysis? Well, maintenance hemodialysis can certainly be done in these patients. However, the relative risk for death is greater amongst these patients, and this is 2.5 times greater in these as compared to non-myeloma patients. The 2-year mortality is 58% as opposed to 31% in patients who do not have myeloma, and most of this mortality is due to infections. Peritoneal dialysis is also an option in these patients, and there is no increase in the risk of peritonitis amongst these patients. For bone protection, these patients should be given pamidronate. This is given in a dose of 30 to 60 milligrams intravenously every month. But bisphosphonate should be avoided in those with severe renal impairment in whom denosumab has been approved for use. The next slide, please. Now, in patients with myeloma with renal involvement, stem cell transplants were earlier not being offered. And renal transplants were also not being offered to them because of the poor survivals and the high risk of recurrence of myeloma after transplantation. However, with the newer therapeutic armamentarium that is now being used, the average survival of the standard risk patients with myeloma has increased to around 8 years now. And myeloma is thought to be curable in up to 20 to 30% of patients. And therefore, both stem cell transplantation and renal transplantation is being offered to patients with the renal involvement currently. So far, up to in 2019, renal transplantation after stem cell transplantation has been reported in 23 patients. However, one of the major problems after renal transplantation has been that 40% of these patients have a myeloma relapse after kidney transplant, and it's not really clear what should be the ideal therapy to prevent relapses, but most people believe in using bortezomib or daratumumab to prevent relapses after kidney transplantation. So if kidney transplantation is planned, this can be done at 6 to 12 months after a stem cell transplant. That would be the ideal time to offer a kidney transplant to these patients. May I have the next slide, please? And that's the last slide. I'd just like to briefly mention the entity of MGRS, or monoclonal gammopathy of renal significance. This is a monoclonal gammopathy that occurs in the absence of myeloma and differs from monoclonal gammopathy of unknown significance by the presence of kidney disease. The types of kidney disease that you see in MGRS include amyloidosis, which is the commonest variety. You can also get MIDD. You can get proliferative glomerulonephritis with the monoclonal immunoglobulin deposits. You can get cryoglobulinemia and immunotactoid or fibrillary glomerulonephritis. However, it's important to note that cast nephropathy is not a part of MGRS. If you see a cast nephropathy, this again is a myeloma defining event, and this rules out MGRS. It straight away confirms the diagnosis of multiple myeloma. And in MGRS also, you can have involvement of organs other than the kidney. The treatment of MGRS is very similar to that for myeloma, and in particular in patients who have amyloidosis, very recent data show that daratumumab is the drug of choice amongst these patients. So I'd like to end here, and I'll be happy to take up any questions that the audience may have. Thank you very much indeed.
Thank you, Vinay, for that exceptional lecture. And as always, one learns so much from your lectures. And I'm sure the students and the DNB students would have, there wouldn't be a question, I can tell you, in the exam, if you have a patient with multiple myeloma, 95% to 100% questions which are likely to be asked will be covered in this talk. So what I would suggest to all the candidates who are going to appear in the exams to keep these slides in mind. I hope Vinay allows these slides to be given to the students so that they can refresh their minds with all these answers which you have in your presentation. I think I have been an examiner for so many years that I can't find a question which is being asked to the students on multiple myeloma and related diseases that will not be covered by this. And I think extremely useful Vinay lecture, and I learned quite a bit from this. There are a few questions which are already here in the chat box, and maybe I can pick up some of these questions. Some of them you have answered actually. And the question is, when do you consider doing investigations like urine protein electrophoresis? Is there a specific indication? How many patients can be missed on serum-free light chain assay, SPEP, or immunofixation studies?
Yes. First, the second question first, that how many patients can be missed on serum protein electrophoresis? That's an important question that I've been looking at. If you do only a serum protein electrophoresis, you can miss as many as 20% of patients. This is clearly mentioned in the literature. And I have been often perplexed as to what to do when I see a patient with CKD of unknown etiology and I am planning to investigate for myeloma. And I don't want to put a big financial burden on these patients. Many of them will not get investigated if I put too much of a burden on them. So I'm often perplexed by that dilemma. So what I do in that situation is advise a serum protein electrophoresis and a serum free light chain assay. I avoid the immunofixation. So this is the combination that I would go with if I want to save money. But if you ask the hematologist or oncologist, they certainly would ideally want all three investigations. There's absolutely no question that ideally I would like to have all three investigations when I'm treating a patient. But if I want to save money, then the serum protein electrophoresis and the free light chain assay would be what I would like to do.
Yeah, I think
Coming
98.
to the urine.
Yeah, Vinay, you can go ahead.
Yes, coming to the urine. Now, if you merely want to look for light chains, you can do it with the sulfosalicylic acid test, or you can do it with the protein creatinine ratio, and they will pick up light chains. Provided the urine is free of albumin, there is no problem. However, if you have albumin urea as well, then the urine protein electrophoresis becomes important. And similarly, the urine protein electrophoresis also helps you to pick up light chains. It's more sensitive because when you have only light chain protein urea, most of the light chains get excreted in the urine. And so that is the most sensitive method of picking up free light chains in the urine.
Yeah, I was saying that actually, if you combine all three tests, serum free light chains, serum protein electrophoresis, and immunofixation, then about 97 to 98% of patients will be picked up. You will miss about 2 to 3% of patients still.
Yes.
But the sensitivity of these tests increases when all three of them are done. If only serum free light chains and protein electrophoresis is done, then probably around 93% sensitivity is there. So 7% patients will be missed. There's another question that would you recommend myeloma screening in all patients above the age of 40 years with unknown nephrotic syndrome or unknown renal failure?
Yes, I would certainly do that. It's unless you've been following a patient for years with a nephrotic syndrome, that's a different kind of situation, and you've done a biopsy earlier or something like that, that would be a different situation. But a patient presenting for the first time with CKD of unknown etiology, yes, then I would certainly do this investigation. I wouldn't miss it out.
Yeah, I think Vinay emphasized it again, and I will like to also emphasize that despite having a high index of suspicion for multiple myeloma, you continue to miss multiple myeloma in your clinical practice. You get surprised that patients whom you had considered to have had no suspicion of multiple myeloma, and still you will at some point of time find that this patient turns out to be a multiple myeloma. And I remember a conversation which Vinay and I had when I was at Sanjay Gandhi Postgraduate Institute. We published I had sent, Vinay was the editor at that point of time of Indian Journal of Nephrology. And we had sent an article to him, and he said that how come you find so many patients of multiple myeloma in Sanjay Gandhi Postgraduate Institute? And I said that we had missed one patient, and this is a question also that when would you suspect multiple myeloma in a patient with end-stage kidney disease I was doing a round once in the dialysis unit, and I found that there was a patient who had hypercalcemia. He wasn't on any vitamin D supplements and had hypercalcemia. And then we found that his kidneys were good sized kidneys. So we did a biopsy of this kidney along with a bone marrow. And we found that this was actually multiple myeloma. In fact, we treated that patient multiple myeloma, and his kidney function improved, and he was off dialysis for some period of time. So that's what I think. Whenever you have a suspicion for multiple myeloma, and Vinay has given you when to suspect multiple myeloma, you may have some of those questions, and then you should be looking for this. Vinay, you want to make a comment on when do you suspect multiple myeloma in an end-stage kidney disease patient? Any other comments?
Not really. I think I've covered most of those. You mentioned hypercalcemia. That's certainly a very important clue. If you have hyperglobulinemia, that would be important. If you have, generally these patients will have normal sized kidneys. We've already talked about anemia out of proportion to the degree of renal insufficiency. So I think these are some of the important clues. But even in the absence of these clues, I think you should still evaluate these patients.
Yeah, especially if there is an unknown cause of chronic kidney disease. I think
Yes.
Then multiple myeloma should remain an essential disease to be ruled out by the tests that have been mentioned. Another question is use of erythropoietin in multiple myeloma anemia with CKD or in dialysis population.
Yes. Erythropoietin can certainly be used in these patients. It's not contraindicated, but these patients tend to be resistant to erythropoietin, and they also have myelosuppression because of if they are on chemotherapy. So you may need much larger doses of erythropoietin than you use in patients with CKD of non-myeloma etiology. So certainly you can use erythropoietin, and you may need much larger doses.
And there is a question on bisphosphonates in patients with AKI and multiple myeloma. You also talked about it actually.
Yes, I would in a patient who has AKI due to myeloma, I would at least during that phase avoid use of any of the bisphosphonates, because almost all of them have some nephrotoxicity or the other. Pamidronate is the one which is supposed to have the least nephrotoxicity. So I would tend to wait until hopefully the AKI recovers in a patient with myeloma. And if the AKI turns out to be paraprotein dependent and does not recover, in that case, yes, I may go on to use pamidronate, but that too only if the patient doesn't have severe renal impairment. If the serum creatinine is more than 4 milligrams per deciliter, then I would not give a bisphosphonate.
Another question is there any difference in the outcome of cast nephropathy or MIDD?
Yes, I would say there is some difference. In cast nephropathy, there is a greater possibility of recovery than there is in MIDD. Cast nephropathy is one situation where bortezomib-based therapy can also lead to recovery. So in a patient with a proven cast nephropathy, I won't go for light chain removal techniques immediately. I would first put the patient on bortezomib based chemotherapy, wait at least a couple of weeks, and if the patient does not show any improvement, then I might consider offering him plasma exchange, but with the understanding that there are no guarantees that this will improve the outcomes. But so I feel that cast nephropathy, there is certainly a greater possibility of recovery than in patients with MIDD.
Vinay, another question is, should we treat AL amyloid with 2-drug or 3-drug-based chemotherapy?
Oh, certainly with in case of AL amyloid related to myeloma, you should not treat it with just one drug. You need to treat it with more than one drug. You need to treat it with more than one drug. But I'm not the expert on the best combination to be used. So I think I would leave that for a hematologist to decide.
I think it's extremely important to involve a hematologist, hemato-oncologist in the treatment whenever you are managing these patients. And I think because there is a lot of newer therapies which have started coming in,
Yes.
and as nephrologists, we may not be aware of the potential of these drugs in specific conditions and the clones that they may be looking at. Another question, Vinay, is that what do you do to a patient who unfortunately gets a kidney transplant and has a recurrence, either from an unknown or undetected multiple myeloma? You talked about it, that this can happen. And what would you do to the immunosuppression in such a patient?
Yes, the immunosuppression would obviously have to be taken off. And if you've developed involvement of the graft because of the paraproteinemia, then you would treat it just as any other patient with multiple myeloma and paraproteinemia. The immunosuppression would need to be taken off, because then you would treat the myeloma just as if you were treating a de novo myeloma. So you would withdraw the immunosuppression. You would withdraw it completely, virtually.
Yeah, we have had 2 patients who developed multiple myeloma post-transplant, and we had to withdraw immunosuppression. Obviously, steroids continued, but tacrolimus and mycophenolate mofetil were withdrawn, and they were on bortezomib and other immunosuppressive drugs for myeloma. I also must share that I have had a patient who had multiple myeloma and went on dialysis and got after the remission with the drugs, he got a stem cell transplant in US, came back, and in 2007 we did a kidney transplant, father being his donor. He's doing still very well, no recurrence of multiple myeloma, although he has another set of stem cells reserved for him if he had a relapse after that. But he has done extremely well over the last 13 years. His father, who is about 88 years now, who was the donor, is also doing well. And both these patients are doing well. I have had 2 patients of LCDD and MIDD who have had stem cell transplant. This was done in All India Institute of Medical Sciences. There was an improvement in their kidney function, and they are also doing quite well. They are not on dialysis as yet and are doing quite well. So stem cell transplant and a cure of multiple myeloma these days is possible. And I think that's something which has started happening in our country as well. One question on kidney biopsy and myeloma. Actually, you had covered it in your talk. Would you want to make a specific comment or something?
Nothing really to add, unless there's something specific that they are asking about it.
Which antibiotic prophylaxis would you recommend following chemotherapy in multiple myeloma, and when to start and how long would you continue it? Would you suggest antibiotic prophylaxis?
Generally, what these patients are given is a combination of cotrimoxazole, low-dose acyclovir, and fluconazole. So this is the combination that our hematologists are using currently.
Another question, Vinay, is that can we use serum-free light chains only as a screening method rather than doing a SPEP along with serum-free light chains?
Doing only light chains.
Yes.
See if the patient is producing intact immunoglobulins, then you're not going to detect those
yes.
in a free light chain assay, and that too can be happening in some patients. So that also is not adequate.
I think we have covered, to the best of my Joytosh, is there a question which has not been covered? I thought we've covered almost.
Yes, sir. All are covered, sir.
All are covered. So I think time we've already shot by about at least 10 minutes, 10, 15 minutes. So I think I must thank Vinay for that exceptional lecture, and I would like to thank all the participants. I'm sure they would have found this extremely useful. I'm sure you're going to find it out when you get a case like this in the exams. Then you are going to know the real value of this lecture. And this lecture has a lot of practical day-to-day sort of emphasis, which will be extremely useful in your day-to-day practice. And I'm sure you will be reminded of this lecture time and again in your daily practice that you do in these patients. So with this, I must thank MCure for providing the logistics support and doing the hard work. And Vinay, exceptionally good. Thank you. As usual, you've been exceptional. Thank you very much. And I
thank you very much for choosing me for this session.
You can't be left out. Vinay, how could you think of that? There can't be a program without you being the leader for this. And thank you very much for your exceptional lectures. Thank you. And good night, everybody. Have a good evening.
So Dr. Kher, sir, and Dr. Sakhuja, sir, my heartfelt gratitude to all of you for being part of this program and helping us starting this MentorSpeaks program. And I would also like to thank all the attendees who have joined us today. And without your presence, I would surely say that this could not have been successful. As the great Mahatma Gandhi had guided India to freedom, I hope that with this session, our mentors had been able to guide you in this particular topic. And we hope that you enjoyed the discussion also. And we promise to come up with another interesting topic very soon. At the end, I would also request you to please share your feedback and your topic of choice, which you would like to hear in the next session with us. Thank you.
The next session is going to be membranous nephropathy, will be done by Dr. Raja Ramchandran, and it would be probably informed to you. It's on 16th or so, whatever. We haven't finalized the date yet, I guess.
Yes,
okay.
Sir. Yep. Thank you, sir.
Okay. Bye-bye.
Thank you very much. Thank you,
Joytosh
and the MCure team. Thank you very much indeed.
Thank you. Thank you, Vinay.
Thank you. Thank you, Vijay.